and this inauguration was started with 20 ambulances as a pre-hospital care, and within no time, within 1 year of the time, we reached it to 400 ambulances. And it is not question of only ambulances. We provide all backups. Our EMTs were given a training, 6 months training, and they've been very well trained. And this is the center which was created for the very purpose of it. I don't know why this is moving. It's not. How this is not remaining there. We are out of control. So this is the center we built up about 20 crore rupees, and it is a state of an art which has central control as well as it is also an educational area. If you look at some statistical figures, they are mind-boggling because we have 33 districts and we cover about 18,000 plus villages. 536 ambulances are there. The most surprising figure which came out from emergency, because you know how these ambulances started coming is under the NRHM program. That is a national rural program made for the reducing of the maternal mortality. So that is how the program came. And then you know the facts come out true that our highest call which we received related to the pregnancy, and they were about 33. But the second thing is that the second most common call which we received was of a trauma. And that opened up that we have to build up a system by which our EMTs has to be very well known. We have about 2,600 people working in this organization now. So the present situation is now we have one state number of emergency 108 and it is almost going to be a national. We cater all three services at one point of time. As we know that many times the police has to come, has to create a police case like that. But now what happens, the moment you ring 108, the police, fire and medical people are all sitting in the one center. All three services will be going at the site of the trauma or at the site of the victim, and they will immediately finish up whatever is required over there. So that is how the time which has been getting wasted for those things has been reduced or almost made nil. At present, we have got two kinds of ambulances, basic life and acute life support. And these are gradually we are increasing and making them from BS to LS. At present, we are operating 143. Their paramedics are well-trained, more-trained. They have some kind of intervention kind of a training. And they also have ventilators and defibrillators inside the ambulances. We train our pilots. We don't all tell them drivers, but they are pilots of the ambulances. They are trained on a simulations. And this simulation is one which they have to practice it and they have to pass in the exam. They are given a communication kind of a training also. So now this is how the mechanism works. Once you dial 108, it will be picked up on the very second ring, and then communication officer will dispatch the ambulance, and the dispatch officer will be in continuation with the caller. He will reassure. By that time, he will assign the ambulance, which is the nearest by. We have got a GPS kind of a system and Google kind of a system by which he can make out which ambulance is nearest to the spot from where the call has arisen, and immediately that will be given. And that's how now we can say in a confident manner that over a period of 7 years, we have very well established pre-hospital system, and that gives laurels to us. What has happened now, every politician is running after us that you bring more ambulances in my area, because it has become a political tool for them, that this is the services which we created like that. So now, initially we wanted to sell 108 to the people, but now we are known by 108. Once we say that I am 108, then you know people's attitude immediately changes and they start respecting you. But the problem was of hospitals, because this is still emergency area which was the biggest area, and it required training and integration. Rehabilitation is not a acute phase, but later on we also have taken into account. So we realized all those issues which were there. So our goal was accurate and rapid assessment inside the emergency, resuscitation in order of the priority, provide optimum care, determine the need. And this is the slogan which I think whole India should follow. Right patient at right hospital in right time. If we achieve this, I think then that most of the things which might have achieved. And of course, lastly, we always add that do no harm. Many times in emergency, if you are not well trained and protocol based, you might create some problem for the patients. So to study the trauma system, I say system, we went to Israel, who has one of the world's best area of creating system of trauma management. And from there we learned it, and we opened up trauma center in our hospital. Initially it was 85-bedded trauma center, which was, again I told you, was bomb blasted by the bringing of that ambulance over there. But when we realized that, this is not going. Okay, regarding training, we realized that EMTs, that is paramedics, are not having any kind of university qualification or certification. There is no college which offers that kind of education even. Our doctors, they once in their lifetime, they pass MBBS or they become MS, they don't go for any kind of training. And our nurses, again, they only pass their degree and then that's all. That means in life, once only you are qualified and no further training or no further kind of education you are getting. So this was a very big gap. So we realized that the training part like ATLS, BLS, CPR, all things are very much important for not only medical doctors but also for the nurses. And for the paramedics, there are no institute in India which gives that kind of so we have to look abroad and find out from where we can. So this legislation also helped us to push those areas. We encourage EMS network. What is that network? We will do it. So these are the 15 areas where the EMS is basically very much involved in every kind. How these are involved, we will just see one by one. This is what we have already implemented. We have created an authority. This authority is of 18 members people, which is public and private and stakeholders. It is not only government, and it is an autonomous body, and everybody puts into it. They decide the policy, they decide the curriculum, they decide the process, they decide the protocols and everything. And then we have subcommittees of experts, like, pediatric emergencies there, we call pediatricians also. Or if it is a trauma, the orthopedic surgeons and general surgeons. If the gynec emergency is there, we call the gynecologist also. Like that. So there are subcommittees. So we started doing that. And we also started getting, EMT colleges to be qualified, because the institute has to have some kind of infrastructure and people who are really that. So objectives which were there, half of it was already achieved. That means single number, our entire state. Set different standard of ambulance and set training requirement, that also we have already done it. And now we have attached our EMT degrees with a university qualification so that they can have a perfect degree in their hand about which they will be proud. The fundamental question which Manjula has talked about is the accreditations. Now if we follow that slogan of right patient, right hospital, right time, then this accreditation has the immense importance. Because when we talk about right patient, that means our EMT will at the site will decide whether this patient is serious, that means red category, yellow category, blue or green category, like that, by the training which we have given to them. Once they decide that this is the red category, requires immediate transfer with minimum distance to travel, immediately he will look at his diary where he has been given the nearest trauma centers of level wise. That means he will immediately know that the red category trauma center which are available within my area of 10 kilometers radius are 2 or 3. And out of that 3, which is the nearest. So that is accreditation of trauma centers. So once we do accreditation of the patients, accreditation of the trauma centers, and that's how we reach in right time. The one sector which was still remaining vacant is that before reaching to the hospital or the trauma center, we were not able to inform them. And I'm very glad that we have been made a part of AIIMS with our Australian colleagues, and we are thankful to Professor Mishra that we are also made a part of that study, by which now we are developing that system by which every hospital protocol is transmitted to the hospital where we are bringing the patient, and they will know it and they will be prepared, and that's how the time will be reduced. So that is how these accreditations of the patients, accreditation of the hospitals, even accreditation of the ambulances, we have already said. And then by this network, we will be able to at least save number of lives. That's what our aim is. I'm not going into ambulances. Just to tell you that during our recent visit, as AIIMS is also going for helipad emergency setup, we are also Pankaj's hospital, EAS Hospital, whose diagram is there, and my hospital, Civil Hospital Ahmedabad, we both are also having a helipad. But we don't have infrastructure or detailed mechanisms. And we are very much lucky that we are going to share and we are going to get those information from AIIMS people, and we are trying to get this in our center also. These are the functions of the authority. I don't want to go into that. We started PG, and already first candidate of qualified emergency physician has been out from our institute. What should be the future directions? Especially AIIMS taking a lead role, and they are the role model. We request them that there has to be a national phone call number for every emergency. Standardized National EMT Training Institute is the time. Standardized ED physician training has to be there. We have to have a standardized protocol. There is no question of discussion when the patient comes. It has to be 1, 2, 3, 4, 5, that's all. Not my or your thinking. Rural outreach has to be addressed. Research and development has to be done. And starting of emergency medicine residency in emergency medicine as well as in trauma is a need of an hour. Well, we talk about training and how did we overcome that, because without training my staff would not have worked well. So that's why our friends from AmeriCare, they provided certain funds to Columbia Cornell hospitals, and we started for next 3 years. The faculties from them came over to our hospitals and started training our faculties. Now these faculties were also exposed for the first time that what kind of mechanisms or what kind of way the emergency medicine has to work and how the emergency is to be tackled. They brought everything with them, and gradually we started taking up ourselves. The trauma courses like anti-MC we have created of our own, where Pankaj and Manjul and myself and Harenbhai, we have 4 people who have taken up that task, and we have started teaching that. We also involved the district people because we know that the trauma is not only isolated to tertiary care, so we started teaching them also. We have faculties from Cornell hospitals also. We went there and we studied their mechanism. We stayed there for 3 weeks and see how the processes are taking place, what are the difficulties. And this kind of knowledge for the doctors was there. But then we started EMT training also. Here again we involved collaboration with the North Shore, Long Jewish Island people, and Dr. Dario, who was the emergency director of the New York Fire Brigade, was kind enough to come. And we started training the first batch in Gujarat of the EMTs who will be working in the ambulances. I visited their EMS academy, found out their curriculum, their course module. We tried to modify that as per our need. And then we opened up, because of some private donations, we opened up a institute of EMT training at our place. And this is a joint collaboration from foreign faculties, from Indian origin people who have settled there, and our Indian people which we are localized over there. So it was a joint venture like that, but because everybody has some things to do for the community and for the people of Gujarat, that's how it was done. And this is how and then we did a drill in our hospital with EMTs whom we have trained, and the mock drill was created. And to our surprise, after 4 months of this drill, we had those serial bomb blast in our hospital. And because we have done this drill, we could very well manage that kind of an emergency when it has arisen. So I think that what we sweat in the cold time helped us in the bleak time. And you can see the stakeholders, all of them are there. Dr. Dario is there, Bristow is there, Arenbhai is there, all of us there. And then we started, this is the first faculty of emergency medicine which we started. And again it is a difficulty because 2 of the surgical faculty we pulled, 2 from anesthesia, 2 from medicine, and that's how we created 2 minutes. And this is the MCI which recognizes us. We gave paramedic training. These are the 15 elements. I don't want to go. There are training. This is the new institute which we have now created, where we are now imparting education to our EMTs and paramedics. This is the facility which is recently created. Communication I told you, which we are trying to in pre-hospital. And public safety, consumer, involve the people, coordinate them. That is what has been already, very much emphasized. We tie up with the University of Southern California for emergency medicine because our faculties were not qualified to be an emergency medicine. So we took their help and we have an MOU and now we have an exchange program which are going on. All these things would not have been possible without legislation, because legislation is the one. As Sir Misra sir has said that 40,000 penalty, 4,000 penalty, like that, without legislation we will not be able to do that. So the need of the hour is that we should have this kind of a coordinated efforts. And what is the future direction? I already told. I was invited to share our experiences in New York. And again, many Indians are having a very positions over there. Dr. Alagappan was there. We have seen these pediatric emergency ambulances. Columbia has director. Professor Carter is a director of emergency medicine curriculum in USA. So and Dr. Bryan is a director of nursing care. So they have an excellent quality control curriculum. Everything was there. And we were lucky to. Simulations again is a part of teaching. Not forgetting our colleagues, which we have started with the AITSC program. This is the new trauma center, which is now we are building up with 350 beds, and it is going to be a state of an art. Somehow or other it has been delayed for some time, but I hope we will be able to overcome that. This video is there, but I think time constraint is there, so we will not do it. Thank you very much.
Thank you, Sir. Any question? We'll take only one question if is there.
This whole services is free of charge, because many times there is a question that who pays for it. The whole cost is borne by the state government. And few things which I like to share is that after 5 years those ambulances became useless. So what is to be done? So then we devised that there has to be a drawback services. Now drawback services like Khilkhilat ambulances. So what we do is every pregnant woman who delivered, we take them back to the hospital or back to their home with a video how to take care of the child and how to take care of the newborn and what kind of nutrition food. So all that educational videos are running inside the ambulance, and we give them a very high nutritive food, 2 kilos of sukhdi. I don't know you know that or not, but it's a sweet which is available. And this is how we created like that. Our EMT program has changed because we cannot adapt the Western model. What has happened that 13% deliveries are taking place inside the ambulance. So we have to train our EMTs how to conduct the deliveries. We taught them, we included them in the curriculum, and then you know how to take care of the newborn. So we have to involve pediatrician and again put those things that this is how kangaroo weighs and how you have to warm the patients and all that. So there are challenges in Indian scenario which are different, and we have to evolve our own systems, and I think we will be able to do that. Thank you.
Can we call upon the next speaker, Dr. Chin Ming Tran, who is currently the head of General Surgery Department and Director Trauma at Tan Tock Seng Hospital and heads the AIIMS program at his hospital. He is also the chairman of the Committee of Ministry Hall Health on National Trauma Committee. Please, Dr. Chin Ming Tran.
Thank you, Mr. Chairman. I come from Singapore. Singapore is a small country, a very small country. There's a land area of 700 square kilometers, which is about half the land area of New Delhi itself. With a population of 5.5 million, Singapore is the second most densely populated country in the world, which also means that Singapore is small and compact. And being small and compact, things can get done more easily. But as you can see, Singapore is served by 7 public or restructured hospitals, 6 adult hospitals, and 1 children's hospital. Trauma in Singapore is only done by public hospitals. Private hospitals are not allowed to do ambulance trauma cases. Well, I've always been asked, is there trauma in Singapore? Obviously, there is trauma in Singapore. Even though our road fatality rate is amongst the lowest in the world, it's about the same as Australia, it's about half that of the USA. And you talk about homicidal rates, Singapore, Japan, and Hong Kong, we are absolutely right at the bottom. And yet, trauma is the 5th leading cause of death in Singapore. Where do the trauma cases come from? In Singapore, 2/3 of major trauma actually comes from high impact falls, fall from heights, not from road traffic accidents. And that's because over 90% of the people in Singapore work and live in high-rise buildings. I must say that the trauma system in Singapore is still in its evolutionary state. It's still a system in evolution. We only started the system in 2008, and that's less than 10 years ago. It's based on 3 aspects: pre-hospital care system, which my colleague will later elaborate on; the hospital care system, we have a tiered system; and a post-hospital system, where we set up rehabilitation hospitals to rehabilitate patients who are discharged from the acute hospitals. So our trauma system actually started in 2008 when the Ministry of Health appointed a National Trauma Committee. And the purpose of this committee is to formulate a trauma care system to develop the system in Singapore into a world-class trauma system. So in 2010, the committee developed minimum standards of acute care for trauma for all hospitals who want to manage trauma. Therefore, all public hospitals had to meet these minimum standards of acute care for trauma. These standards are based on 3 aspects. 1, every hospital must have an organized trauma system with adequate resources allocated to trauma care. 2, manpower training. Example, all doctors who manage trauma must be ATLS trained. And thirdly, all hospitals who want to manage trauma must participate in the National Trauma Registry. So it is mandatory for hospitals who do trauma to be part of the National Trauma Registry. And we carried out site validations in 2012, and all 7 restructured hospitals were concluded to be compliant with the standards, and therefore allowed to manage the majority of trauma cases. However, we cannot have a country just with hospitals, trauma centers meeting minimum standards. There are trauma cases that are too complex for hospitals who just meet these standards to manage. And therefore, we set up another level of standards, and that's the Tier 1 trauma center standards. The Ministry of Health arbitrarily appointed 3 hospitals to be Tier 1 hospitals. These are the tertiary centers in Singapore. We have yet to validate these hospitals, and that will be the next step in our development of this system. To validate the Tier 1 hospitals to make sure that they meet the standards set up for Tier 1 hospitals. Singapore has also been divided into 3 regions: East, West, and Central region. And each region is helmed by 1 Tier 1 hospital. So there are 3 Tier 1 hospitals in Singapore. And these Tier 1 hospitals are responsible for the trauma outcomes of that region. So they are supposed to work with the Tier 2 hospitals. And they work based on a push and pull system. That means if there's a case that's too complex for a Tier 2 hospital to manage, these patients should probably be transferred to a Tier 1 hospital. If by any chance these patients cannot be transferred, then a team from a Tier 1 hospital has to go down to a Tier 2 hospital to help manage. Example, interventional radiology. Okay, interventional radiologists can move from a Tier 1 hospital to a Tier 2 and do the interventional radiology, angioembolization in a hospital that does not have interventional radiologists on duty. We are also a trauma training hub for the region. We run courses like the DSTC, Definitive Surgical Trauma Care, ATLS, emergency ultrasound courses. We run the PHTLS for paramedics and Advanced Trauma Care for nurses, ATCN. Every year we have a Singapore Trauma Conference. It is a regional meeting where 50% of participants come from the region, and it is serves as a platform to connect doctors, nurses, allied health from all over the world. Our National Trauma Registry started collecting data since 2011. And as I mentioned, it is mandatory for all hospitals who manage trauma to participate in this registry. So this registry, besides collecting data that shows us what is the load, the burden to Singapore, it also is able to come up with QI indicators, quality indicators. And we are able to, number one, see how we are performing. So crude mortality rates. We are able to compare whether there's any improvement, which you can see there's an improvement, gradual improvement in our crude mortality rates. And this is the crude mortality rate for ISS cases 9 to 15. These are cases that are not expected to die, and yet there are cases that die. And all these cases have to be audited and reports submitted to the National Trauma Committee to see why these patients died, whether any of these were avoidable deaths. What is also very important is that we are able to break down these rates, these outcomes between the various hospitals. And this proves to be a very powerful tool, because no hospital wants to be seen as the hospital with the highest mortality rate. And therefore, this is a great impetus for hospitals to want to improve their trauma care. We know that we cannot just exist on our own, and we are actually part of a larger group of people. And therefore, in 2012, the ASEAN Trauma Group was formed in the Philippines, and we organized the first ASEAN Trauma Conference. Currently, Philippines, Malaysia, Singapore, Brunei, Thailand are actively involved in this group. Invitations have been sent to Cambodia, Myanmar, Indonesia. This group organizes an ASEAN Trauma Conference every 2 years. It's on a rotating basis. Every country takes turn. So the next conference will be in Malaysia in 2016. Currently, my hospital, Tan Tock Seng Hospital, we are also involved in setting up a trauma training center in Cambodia. We are working very closely with the Cambodians. Naref there is our main person that we work with. And we are also setting up a trauma registry in Cambodia. And this registry will probably go online next year. With that, I'll invite my colleague to say a little bit more about the pre-hospital system.
So sorry guys, I think they did not load my PowerPoint, which already emailed. So hang on a minute. Okay, can you? Well, we are setting up. Let me just give a brief introduction of myself, okay? I think I'm very different from most of you. I come from the Singapore Civil Defence Force. If you all been to Singapore, you probably know we are under the government service for emergency under the Ministry of Home Affairs. Okay, so we handle all the fire cases and the ambulance cases. Okay, today I just want to give you a brief introduction and an overall view of our. Hang on, A brief introduction of our EMS system in Singapore and our trauma capability. I think it's hope that it's a good sharing session and then so that we can learn from each other. All right. Okay. East Asia. Okay. All right. Singapore Civil Defence Force. In short, we are SCDF. Okay. I myself is an ex-paramedic and I do fight fires before in the past. But currently, no. I'm just handling clinical audits and trying to find out all the training gaps in all the Singapore EMS cases. Do investigations and then hopefully can improve our system. All right, so yeah, this is some of the photos that I've taken over the years as a paramedic and a fire commander, and currently doing audit. Okay, I've been to Queensland, Australia too, on the top photo for attachment. I think I do not need to explain about Singapore population. And what kind of society we are, as Professor Chu already said. Okay, for Singapore, we handle we handle about 5,000 fire calls a year and about 155,000 trauma and medical cases. Occasionally, we have the complex rescue incident like the Hotel New World collapse in 1986. Nico Highway collapse in the year 2004 and some cable car incidents. Sometimes we also handle hazmat incident like chlorine leak from swimming pools. Okay, to tell you a bit of history, we need to go down the memory lane. This is how our ambulance looked like in the past. Okay, before 1977, we actually have two organizations handling our emergency cases. The fire brigade will take care of the fire cases, trauma, and the hospitals will take care of the medical cases. Then in 1977, we actually merged both of them together into a single-tier system where the nurses and midwife come from the Ministry of Health to run in the fire stations. Okay, this is how we look like in the 1970s. Like a minivan to the current ambulance. Okay, and okay, in order to improve our response time, we actually started a fast response medic in the 1992, and we evolved to the current fire bikers, which is a three-wheeler. I will talk about it more later. And our current EMS skills system is like this. Okay, in the past it's just first aider and nurses. Now we have fire biker, which is cross-trained to handle medical cases, and paramedics on wheels, and also paramedics and private operators. This one I will also explain a bit more later. And there is also, in future, we wanted to have a active community layer to help us with all the like cardiac arrest cases. In order to transit from the nurses to paramedic, we actually got JIBC, okay, from British Columbia, accreditation, and form a single training school run by our Singapore Armed Forces, which is like military. And this is in this school. All our paramedics were trained there, but they did their attachment in the hospitals and also our EMS system, which is equivalent to 108 in India. We have a emergency number 995. Okay, since 1996, this is the year that marks the beginning of our EMS. Before that, it is all nurses from our hospitals. Okay, since then, our ambulance call have increased year on year 5%, okay, to the current 155K, considering that we are a very small country, and it's quite a lot. With the aging population, 1/3 of our calls are actually for patients above 65 years old. And our clinical demands has actually changed over the years. In the past, it is all younger population with acute illnesses, to the 1990s where there are older patients and chronic illnesses. Then year 2000, we see a huge increase of calls, which we have to focus on the increase of our capacity, and also focus on the paramedic training programs. And from 2010 onwards, of course, we have a different kind of tsunami, which is the aging population tsunami. Okay, pretty much the same as in Japan. And we have multiple chronic illnesses, and complex care is needed. Thus, we need to have paramedics who, although protocol-based, we are moving towards critical thinking. In order to increase the capacity, we actually collaborated with, we have to expand our sources of paramedic education. We collaborated with a vocational training school to provide paramedic training. They have to complete 2 years of enrolled nurse followed by an extra year of paramedic training. So actually they can branch as both nurses and paramedics. Then in year 2009, we actually have to outsource to private sector so as to increase our capacity. They operate within our premises, which is at the fire station and the fire posts, but they also have the same protocol and equipment, but at a much lower cost. But the only thing they don't do is do hazmat or incident management. With regards to training and upgrading, we have also moved towards improving the basic education of our paramedics with formalization of the paramedics into advanced diploma education. The advanced diploma education also, we also try to increase their skill sets, okay, to something like advanced cardiac life support, pre-hospital trauma life support, and advanced pediatric life support. These are our paramedics are trained in this. And to enhance our operations, we actually have a firebiker program that we started in 3 years ago. These are actually firemen who are cross-trained to handle cardiac arrest case. With these firemen, we are able to actually reduce the response time by about 2 minutes per call, as they can weave through traffic. As you can see, there are 3-wheelers, which is much more safer than the 2-wheelers. Okay, it actually makes sense for us to upgrade our fireman capability, as we have less than 5,000 calls a year compared to, and it is still decreasing, and compared to our increasing medical call of 155,000. Imagine we have about 2,000 firefighters, 2,000, to handle 5,000 calls, where we only have 200 plus active paramedics on the road. So we have to train them to be EMT level so as to improve our response tremendously. And our current system is a 2-tier system where we promise to be there 80 minutes of time in 80% of the time in 11 minutes. And we have only 50 ambulance, okay, attending to all the calls, and 40 fire bikers, those that is in the 3-wheelers. Our capabilities is extrication in road traffic accident, spinal management, fracture, arresting hemorrhage, setting IV and IOs, burn management, okay, mass casualties, and hazmat incidents. Okay, we actually encourage our paramedic to come up with innovative ways to improve operation effectiveness. For example, this mass casualty incident kit enable our paramedic to triage and organize patient in a systematic way, which result in faster transport to a definitive care facilities. And with better communication, we can have better outcomes. You can see this is a board, and it actually works much better and more organized. And we also have a transformer vehicle, which we call it the SWIFT, Station with Immediate First Aid Treatment. Okay, this vehicle can transform into a mobile hospital in severe mass casualty incidents that we can use to provide oxygen, handle on-scene surgeries, and store extra first aid supplies. And for hazmat incident, we have a mass contamination setup. We have all these vehicles that will set up to form a perimeters around the hazardous zone, hot zone. And this can effectively decon them before we send them to the first aid post and the hospitals. Okay, finally, as you can see, I think Dr. Chu already said, actually we actually have 2/3 of all severe trauma cases arriving through our emergency ambulance. Okay, most of them call us, and only a small number, okay, come by private ambulance or their own transports. Okay, these are figures actually provided by our trauma registry, okay, which is very useful. And according, in relation to the mechanism of injury, the most common type of trauma in Singapore, yes, is fall from height. Too many tall buildings, which is above 20-story high, and followed by motor vehicle accident. Of all the motor vehicle accident, in fact, 85.5% of them actually comes through our ambulance, which is quite good. This is what we want, because we can give them more better first aid care. Okay, finally, most of our trauma cases come from elderly, as I said earlier, and a majority of the youngsters, in fact, okay, from the 17 to 24 years old, came to the hospital by our 995 ambulance. So in summary, our paramedics system is actually still very young, less than 20 years of history, and our biggest challenge now is to increase the capacity to handle the aging population and to focus on upgrading our paramedics education so as to meet the needs of the complexity of care. And of course, like many countries, fall and road traffic accident is still our main cause of trauma. Thank you for your attention, guys.
Thank you very much. Any questions? Any other? Okay, otherwise, we come to close of the session, because the listed speaker, Professor Gautam, has expressed his desire not to present. He feels that many of the tasks have been taken. So I, on my behalf and behalf of all our chairpersons, take this opportunity to sincerely thank Professor Mishra for giving us opportunity to share this interesting session, and with all eminent speakers sharing thoughts with us. Thank you so much.
Okay, we give a sincere thank to respectable chairpersons and speakers. Now, just at the end of the session, I would like to request Dr. Parija to just give the mementos to the speakers. So first, Dr. Parija, please give the token of love to Dr. S. Raj Sabhapati. Dr. Sharad Vyas. Okay, now to Dr. Vijayashil Gautam. Now I would like to request Professor Pankaj Patel to hand over memento to Dr. S. Parijan. And Dr. Satish Dharat. I will request Dr. Pankaj Patel to hand over the memento to Dr. Satish Dharat. Now I will request Dr. Amit Gupta to hand over the memento to Dr. Pankaj Patel. Okay, so I'll hand over the.
We'll come to the formal closing of the formal sessions. Actually, one-on-one meetings of the East Asian countries are going on one by one with the organizers, that is the Director AIIMS right now. You may please be seated and join us for the high tea, which is served at the same place where the high tea was served. After this, the buses will take you at around 5 p.m. to the hotel and will collect you back from the lobby at 6:30 sharp, so that we can begin the cultural program followed by dinner at 7 o'clock in the auditorium. So please join us for the high tea at the high tea place. Meanwhile, the country delegations would have one-on-one meeting with Director AIIMS, and our administrative officers will take you one by one. Right now, I think Australian delegation is meeting.